اذا لو حد عرض عليك شيست اكس راي زي دوت كده وقال لك ان الطفل دوت عنده 3 سنين presented by coughing and difficulty of breathing, on examination there is bilateral stridor and bronchospastic cough. This X-ray would be described as normal or hyperexpansion or right middle lobe infiltrate or right-sided rib fracture. What do you think? Yeah. Yes, this is hyperinflation, and this hyperinflation رقم واحد في السن دوت when you think of foreign body inhalation. And you see this foreign body in the proximal part of the chest, and this foreign body لما تشوف الفورين بودي مدور كده في الفرونتال this should be in the esophagus، ولو كان بالجنب يبقى in the trachea. And this foreign body is tracheal ولا esophageal ولا normal ولا error in the film processing. This is esophageal foreign body. Then the complications of esophageal foreign bodies include ما عدا واحد من دول: airway compromise, esophageal rupture, erosion into the mediastinal structures, and heavy metal poisoning. Erosion, heavy metal. Yes, heavy metal poisoning، لأن ده محتاج إن الفورين بودي يقعد فترة طويلة جدا. وبعد كده ايه هو العلاج المناسب؟ هل تعمل فولو اب لحد لما ينزل من الاليوسيكال فال، ولا تشيله بالمنظار، ولا تديله دواء كحة عشان يكح الفورين بودي ويخرجه بره؟ نعمل ايه؟ نشيله احسن. اوكي، يعني should remove by endoscopy علشان الفورين بودي لو اتزنق كده في الاسوفجس في الغالب مش هينزل لوحده، لكن لو هو نزل في الاستومك في احتمال كبير ينزل لوحده. ان وجود الفورين بودي كده مزنوق في الحته ديت بيعمل بريشر على الوول اوف ذا اسوفجس وبعدين التراكيه وبعدين الفيسلز اللي جنبه. ان واحده من الكومبليكيشنز لو قعد شويه يحصل ميجر فيسل ايروجن اند رابشر، وممكن الولد يموت في الوقت دوت. وبالتالي مهم جدا ان لو الفورين بودي واقف هنا تشيله على طول بالمنظار. نعم. لو الفورين بودي انت عملت شيست اكس راي ولقيته هو مدور كده بالوش، يعني عامل كده، يبقى ده لازم يكون في الاسوفجس، لكن لو لقيته واقف كده يبقى لازم يكون في التراكيه. اوكي. نعم. ايه هو كده، يعني الفورين بودي ما يعرفش يقف في الاسوفجس في التراكيه، ما يعرفش يقف كده، لان التراكيه الرينجز ما تسمحلوش ان هو يبقى واقف بالوش كده، بالويتس اوف ذا تراكيه ما بيسمحش بكده، يعني التراكيه از ريجيد. لكن الاسوفجس براحته، ممكن الفورين بودي يقف كده يعمل زي ما هو عاوز. لان طبعا definitely. بس احنا عاوزين نقول ان الفورين بودي في التراكيه الولد ما يقدرش يستحمله خالص. اي واحد بتنزل له نقطه ميه بس في التراكيه بتجننه، لكن لو جاله فورين بودي بيفضل يكح لما يقول يا بس فبيروح على طول. لكن اللي واقف له في الاسوفجس ما بيفرقش معاه جامد، الكحه بتبقى بسيطه والبلع يعني كل حاجه ماشيه مش بطال. then افترضنا ان في فورين بودي والواحد بلعه، تفتكر ايه هو المكان اللي يحصل فيه imbaction of the foreign body ما عدا واحد من دول؟ عند الكريكوفرنجيال ناروينج at C6 level، عند التراكيال bifurcation at D6 level، عند الاليوسيكال فالف، او عند الهيتس اوف ذا اسوفجس اللي هي gastroesophageal junction. اوكي، كل الناس عارفين ان لو الفورين بودي وصل الاليوسيكال فالف خلاص هيخرج، لكن لو هو اتزنق في اي حته تانية فانت لازم تجيبه. قد ايه بقى البرسنتج الفورين بوديز اللي بتتبلع وتخرج لوحدها؟ هل هو 10%، 20، 50، 80؟ 80 صح. and this is most of the foreign bodies اللي بتتبلع مش اللي بتبقى aspirated بتخرج لوحدها. Then can you see the foreign body? نعم.
كان في حالة في المستشفى الولد الفورن بودي فوق في الحتة دي
مم.
وكان برضه عمال يقاف وبتاع لا يعتبر واقف فين بقى؟
واقف في التراكية 100%. ده اللي عمال يفصفص كده اهوت لازم في التراكية
كان باين ان هو مدور بنفس المنظر الاسوفيس
فعلا.
يعني واقف
يبقى في الهايبوفارينكس، واقف في الهايبوفارينكس and this should be removed by endoscope على طول. الفورين بودي اللي هنا فين؟ طيب this foreign body عبارة عن مسمار وهو الطفل بلعه وموجود هنا، مش بلعه يعني aspirated وموجود in the right main bronch. Then we came to the questions. What do you think about this case? Yes, foreign body with consolidation and areas of breaking down. Very good. What do you think about this case? Yes, there is a possibility of being an empyema because this lesion did not change while the patient is lying on his right side, and the CT scan confirmed the possibility of empyema by detecting thickening of the wall and enhancement. This means that this is an infected fluid diagnostic of an empyema. What do you think about this? Yes, this is the diaphragmatic hernia because air in the chest is continuous with the air in the abdomen, diagnostic of congenital diaphragmatic hernia, which is one of the commonest lesions in the pediatric age group. What do you think about this? Yes, the hydatid cyst, fluid containing lesion in the lung and another hydatid cyst in the liver, common association. Then what do you think about this chest x-ray? Do you think that there is middle lobe infiltrations, lower lobe infiltrations, upper lobe infiltrations, both A and B or B and C? Okay. Where is the opacities in the lung? Yes, you can see this. This is an opacity, and you see another opacity which is in the base of the lung, which is located here. Then you are in this category A, which is middle lobe opacity, and left lower lobe opacity. This is the right answer. Then what do you think about this? Very good. This is the pleural effusion, which is radiographed in the supine position, and this is the erect film, and you can see the air fluid level. Okay, what do you think of this? Lung abscess, very good. And what do you think of this? Very good. This is pulmonary sequestration, mass in the lung, and the angiogram showed the vessel coming from the aorta to supply the lesion. Pulmonary sequestration. What do you think of this? Deposits, very good. What do you think of this? Yes. Congenital lobar emphysema, very good, of the right upper lobe. What do you think of this? Nematocele, anyone says that? Yes, this is a nematocele. What do you think about this lesion? Fungal ball, very good. What do you think of this lesion? Chronic lung abscess because of the absence of air fluid level. Chronic lung abscess because the abscess is totally containing air. What do you think of this? Yes, pneumonic consolidation of the right upper lobe with pleural effusion. Very good. What do you think of this? In cases of emphysema, you should see some of the lung markings in the emphysematous lung. If you don't see, this is pneumothorax, okay? This is pneumothorax with collapse of the lung against the mediastinum, against the hilum. In cases of pneumothorax, the lung totally collapses against the hilum. But in cases of upper lobe emphysema, the lung collapses against the lower mediastinum. Then this is the pneumothorax. Then what do you think about this? Yes. Sorry, diaphragmatic hernia. Very good. This was the possibility, and you can see air in the chest continuous with the air in the lung. Then we did the barium swallow in order to see that this is coming from the stomach or the esophagus. It was not. And we did the barium enema to see if it is coming from the colon. It was not. Then we have a CT scan, and what is your diagnosis? You remember my rule? Yes, very good. No, it's not cavitary. It's congenital adenomatoid malformation of the lung. If you fail to diagnose diaphragmatic hernia, go back to the congenital cystic adenomatoid malformation of the lung, and this was an adenomatoid malformation of the lung. What do you think about this case of a patient with osteosarcoma of the left humerus? Yes, biliary deposits or micro deposits. And what do you think about this lesion? Lung abscess or infected nematocele, both are the same. What do you think of this case? Yes, bronchiectasis complicating pneumonia, very good. And what do you think of this? Where is the abnormality, left or right? Left, very good. This is the inspiratory and this is the expiratory film. What do you think? Foreign body. Yes, if you see that the lung does not collapse or deflate in the expiration, then you know that there is a foreign body and the left main bronchus. Then what do you think about this lesion? The left upper lobe is overinflated. It crosses the midline, compressing the opposite lung, and this is the lobar emphysema of the left upper lobe. What do you think of this case? We use cough and expectoration. Yes, mnemonic consolidation in the left lower lobe, showing air bronchogram by plain X-ray and by CT. This is mnemonic consolidation. What do you think of this? Pneumothorax, very good. On the right side, the lung collapses against the hilum. This is pneumothorax. What do you think of this? Pneumonia. فين؟ ده الليفت سايد كله، ده البريست شادو، ده البريست شادو. Very good. ده مفيش حاجة normal. This is a normal chest. Very good. What do you think of this? Okay, collapse of the left lung, and if you look carefully to the position of the endotracheal tube, and you can see that has been derived distally to obstruct the left main bronchus, and the endotracheal tube is going into the right main stem bronchus, so this lung is aerated and this lung is collapsed. Then what do you think of this? Yes, dextrocard, very good. And what do you think of this? Diaphragmatic hernia. Air in the chest is continuous with air in the abdomen. Then do you think this foreign body is in the esophagus or in the trachea? Esophagus. Okay, this is the foreign body in the trachea is like this. The foreign body in the esophagus is like this one. Okay. This is a question about this lesion. Complications of this lesion, which is a foreign body, metallic foreign body in the esophagus, include the following except airway compromise, esophageal rupture, erosion of the mediastinal structures, heavy metal poisoning. What do you think? Airway compromise cannot occur with esophageal foreign bodies? It can occur. No. Yes, D. The heavy metal poisoning needs a good time to develop this reaction, and the foreign body is not usually left for this time. Do you think the definitive management of this child is to do follow-up X-rays aiming at this lesion to pass, or just to remove the lesion, or to give cough syrups and so on? Yes, and you remove immediately. These are the common sites of foreign body impaction, except the foreign body, the swallowed foreign body, can be impacted at these sites except one. The cricoesophageal narrowing at at C6, the tracheal bifurcation at D6, the ileocecal valve and the hiatal narrowing of the esophagus. The hiatus, yes, ileocecal valve. This is actually because most of the foreign bodies reaching the ileocecal valve will pass outside the body. What do you think about the percentage of foreign bodies pass without intervention? 10%, 20, 50, and 80. 80, yes, 80%. This is true. What do you think of this lesion? Yes, pneumothorax on the right side. And if you see, yes, very good. This is tension pneumothorax. If you see the pneumothorax is crossing the midline, compressing the opposite lung, then you know that this is an emergency. This is a tension pneumothorax. Then we came to the questions. What do you think about this lesion? First, locate the lesion to the part of the mediastinum. Is it anterior, posterior, middle? Anterior. Then you see an anterior mediastinal mass. It is not that clear in the plain X-ray, and you should remember that the plain X-ray has a very minor role in the diagnosis of mediastinal masses in pediatrics and in adults. Then anterior mediastinal masses are one of three, either lymphoma, teratodermoid, or thymoma. What do you think? What do you think? Thymoma. Yes? Yes, thymoma, very good. This is a good possibility because this mass is compressing the vessels and displacing the vessels posteriorly. Then you know that it does not contain fat, it does not contain calcium. Then you know that this is most likely thymoma. Then what do you think about this? Yes, this is a diaphragmatic hernia. Do you think this is a hernia of Morgagni or a hernia of Bogdalek? Yes, you need the lateral view, very good, in order to judge, but actually I don't have the lateral view, so the diagnosis is a congenital diaphragmatic hernia, either of Bogdalek or Morgagni, according to the site of the lesion, either anterior or posterior. But do you think which is more common, Morgagni or Bogdalek? Bogdalek, yes, Bogdalek, because anterior herniation is a little bit less common. What do you think about this case? What do you think? Yes, very good. This is the normal thymus showing the sale sign, the characteristic appearance, which is the sale sign. And you can see this age is very specific for the normal thymus in the pediatric age. This is a male 14 years old with known to have leukemia. Then the CT showed a lesion in the anterior mediastinum located to what? To the thymus, okay? Then in a patient with leukemia or lymphoma with enlargement of the thymus, you should suspect that the thymus is involved by the symptomatology. Then you know that this is a thymic leukemia. Okay? What do you think of this case? Forget about the head and the abdomen and look in the chest. And you can see a lesion in the anterior mediastinum. And this lesion has a specific criteria. Yes, very good. This is teratoma because of the presence of calcium and also the presence of fat. This is a mediastinal teratoma. Okay, what do you think about this chest? This is the most difficult one because it is normal chest. Okay, and you don't see any masses in the mediastinum. Actually, this is the cardiac shadow. These are the heart, the lung fields. The mediastinum is okay. Though you don't see any masses, this is the normal pediatric chest. Okay, do you see a lesion in this chest X-ray? Do you see the lesion? Air, yes, air where? Anterior mediastinum, posterior mediastinum? Posterior, here. Or here? Anterior. Yes, air in the anterior mediastinum. You should look for continuation in the abdomen. Is this continuous in the abdomen? Yes. What do you think? Yeah, the diaphragmatic hernia, which type? The hernia morgana. Okay. Then, what do you think of this chest X-ray? مش سامع. ايه الإجابة؟ Lymphadenopathy. Very good. Lymphadenopathy because you have a hilar mass here and another hilar mass here. Then lymphadenopathy in the chest have these possibilities, either inflammatory like TB and sarcoid, or lymphoma, or malignant neoplastic like lymphoma and metastasis. You need the help of the clinical history. You need the help of CT to show calcium inside the lymph nodes, for example, and you may reach the diagnosis. This is a 7 weeks old female. Yes, this is the normal thymus in this pediatric age. Whenever the child is the infant, in the infancy, you can see that the thymus is bulky like this. And do not misdiagnose this as a mediastinal mass. This is the normal appearance of the thymus in this age group. Then what do you think of this? Yeah. This is the arch of the aorta, and this is the superior vena cava. And what do you think about this mass? Lymph nodes. And these lymph nodes containing calcium. What is the diagnosis in this age? TB. Okay. Then, what do you think of this lesion? This male child, 6 years old, and you have broadening of the superior mediastinal shaft. This is not the thymus in this age group. Actually, this should be a lesion. Then you should have the CT scan. What do you think? Lymphoma. Very good, because the vessels are floating within the mass in the anterior mediastinum, and lymphoma may originate from the thymus, is known as thymic lymphoma, or may originate from the anterior mediastinal lymph nodes. There is no significant difference between both. It is anterior mediastinal lymphoma. What do you think of this? Teratoma should occur in the anterior mediastinum. A neuroblastoma. This is the posterior mediastinal lesion, and you see calcium, typical of the neuroblastoma, and this was the case of neuroblastoma. Then what do you think of this? Yes, this is the normal thymus showing the classic appearance of the sale sign. And thank you very much.